This week on Surfing the NASH Tsunami.
It's quite a simple idea, really. We're interested in the simplest way to make diagnoses of significant liver disease in patients. We want to make it as straightforward as we can for people to be identified with liver disease, for that to be staged in the community with some sort of fibrosis test, and then for those patients who have clear evidence of liver fibrosis or who are at significant risk, they're then referred in for specialist opinion and further investigations. The purpose of this really is to make it as streamlined as possible, to make it as easy for the primary care physician to be able to risk stratify.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Dr. Stephen Harrison, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guest, hepatologist and hepatology researcher Dr. Ian Rowe of the University of Leeds, UK, as they discuss some findings from Dr. Rowe and his colleague, Dr. Richard Parker, that confound conventional wisdom, this week on the Surfing the NASH Tsunami podcast.
For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up Season 2, Episode 17 of Surfing the NASH Tsunami starts now. So, welcome to the cost-effectiveness corner of Surfing the NASH Tsunami. Last week, Mazen Noureddin joined us to discuss the cost-effectiveness of non-invasive tests when you juxtapose those against the lack of cost-effectiveness for biopsy. And this week, our good friend Ian Rowe is here to look at three analyses emerging from the work that he and Richard Parker are conducting in Leeds, each of which has a seemingly paradoxical conclusion on the best way to make screening more cost-effective. Stephen and Louise are here with me as well. Ian, Louise, and I have one important thing in common that Stephen doesn't share, which is we are each fans of a different English Premier League team that has repeatedly found innovative ways this year to disappoint us. But because this is English football, hope springs eternal. Newcastle might not get relegated. Liverpool might win the Champions League. And Tottenham, I don't even know what to hope for. With that, I've got news in the business section, but we'll put that at the back end. So let's go on and just move to the episode, usual icebreaker. Let's focus on the professional this week. What's one piece of good professional news each of you would like to share? Brave one, go first.
I can jump in there and go first. We've gone past 54,000 injections for vaccinations at the XL, which is excellent news this week, and it's all running smoothly.
You can top that.
And that is excellent. Who wants to go next?
I'm just in Texas, right? So let's see. Professional news. I got a non-professional news. My daughter is selecting her college choice this week, and that's consumed all of our non-working time dealing with what that decision is going to be, making last-minute trips to a couple colleges, talking to admissions officials. So it's kind of a crazy week here. We have a top four. In fact, we probably have a top two. It's University of Texas in Austin or Southern Methodist University in Dallas.
So if I understand correctly, that means that you were trying to decide whether you've got to build walls and barbed wire between the kids' bedrooms or not?
Yeah, pretty much, since I have an Aggie.
For those who don't know Texas, people who go to the University of Texas and Texas A&M roundly and consistently hate each other. There are jokes, there are memes, there's all that stuff since long before there was an internet. So Stephen announced at one point last year that his daughter seemed to have ruled out Austin, and that made him very happy because then he would not have to worry about enmity between the kids. But obviously that's back on the table.
No, it's back on the table. But we'll know. I'll know Thursday. I'm doing one last tour of UT's campus tomorrow, so we'll hopefully have a decision here in the coming days. The biggest issue is the cost, right? One's a state college, one's a private institution. So
the parents are trading off the cost of having to build barbed wire between the bedrooms versus paying for the private institution. Is that how this works? And inquiring minds will be waiting with bated breath all week to hear what the answer is. Okay, Ian, that leaves you. Your kid's too young for college. Top that one.
The stage of your children's lives is very different. I spent this weekend teaching my 5-year-old to ride a bike, which we got to in the end. So she was very proud of herself, and I was pretty proud of her too. But from a professional perspective, I guess the thing that I'm most proud of this week is that I've finally finished, in inverted commas, a web app. First one of my quite long and not very distinguished data career so far, but that helps us understand what the benefits of treatments for NASH might be, both in terms of liver and cardiovascular outcomes. And that's something I hope we'll talk a bit about later on.
I think that's item number 2 on the list, isn't it, of the 3? But yeah, so that's great. I guess professionally, just more of the same, except more of the same in this case means we're getting invited to cover more events, which means we will all be spending, Louise and I and Stephen and assorted others will all be spending a lot more time together, although, as I'll announce at the back end, Stephen is about to get a 3 out of 4 week holiday from the podcast because of one of the events that we're doing. He's very excited about that. This is not video, so you don't see him fist pumping, but it'll give him back a couple hours on a Monday afternoons for a couple of weeks in a row. And with that, on we go. So our primary focus today is going to be to discuss, as I say, 3 findings from work that Ian and Richard Parker are producing in Leeds. But before we do that, Ian, since we have a lot more listeners when we discussed this last fall, and they're not all the same people, could you just take a couple of minutes and talk about the genesis of that work and exactly what it is you're doing there?
Yep. So it's quite a simple idea, really. We're interested in the simplest way to make diagnoses of significant liver disease in patients, in our case in Leeds, but in a way that I hope is applicable to other settings. And really, we want to make it as straightforward as we can for people to be identified with liver disease, for that to be staged in the community with some sort of fibrosis test, and we'll talk about which ones we've used and where the preference might be. And then for those patients who have clear evidence of liver fibrosis or who are at significant risk, they're then referred in for specialist opinion and further investigations. And the purpose of this really is to make it as streamlined as possible, to make it as easy for the primary care physician to be able to risk stratify, tell a patient whether they've got liver disease or not, so that they can receive the appropriate treatment. And we've done that in a couple of ways, really. One is to make blood testing a bit more straightforward. So we give people simple advice about how to investigate following particularly an abnormal ALT, which is the commonest abnormal blood test in the primary care population of Leeds. So we started off by looking at all of the blood tests that have been done over a 3-year period, all just about 1 million of them from primary care, and then looked to see where the biggest issues were, and particularly it was around those patients with an isolated high ALT. And then saying, well, if you think this is fatty liver, by all means look for other causes of liver disease, but make sure that you do a fibrosis test. And at the moment that starts with FIB4, and then following the FIB4, at the moment there's advice to do an ELF test in the community because it's blood-based and doesn't require any access to additional kits. And then there's a next step of a FibroScan for those patients who don't have a reassuring ELF. And that process has been up and running now for just about a year. Obviously, COVID has got in the way of that a bit, and in some ways that has accelerated progress because it's meant that we've been able to put together a one-stop clinic for those patients who have elevated tests. So they come for a single diagnostic session for additional blood tests and ultrasound when needed, and a FibroScan on the same day before a follow-up telephone clinic appointment. So in some way, COVID has helped us, but in other ways it's probably got in the way a bit because the number of patients who would have come for testing previously have probably not come for testing at the same rate.
That's, I think, a really great introduction. And roughly how many patients do you have that you've got the data on and analytics on at this point in time?
So we are up to several hundred patients who've been through the full diagnostic pathway now. And one of the advantages of the way that the systems have been set up is that we have done that in primary care, but we've also done it in specific practices where patients have been assessed for fatty liver due to metabolic syndrome particularly, but also in the community alcohol services. So we've got data coming from a relatively unselected population, from a diabetes-enriched population, and also for an alcohol-enriched population.
That sounds excellent and really helpful. Just to start, you mentioned a progression from FIB4 to ELF and then on to transient elastography, right? What have you learned about that process?
So when we put that process in place, we did so for a couple of reasons. One is that we thought it was going to be efficient, so that there would be easy testing from FIB4 to ELF. And I think as time has gone on, it's become easier, but it still required quite a lot of education in the primary care community that you needed to do both tests before there was a referral for additional testing. And we also did it because we recognised that access to transient elastography, or FibroScan in our case, was restricted in terms both of the location at that point, in that the patients were having to come to the hospital for it, but also in the number of scanners that we had and the number of people we had to run them. So we thought that it would be more efficient. What we've found, though, is that with the thresholds that we've used, the number of patients who are being reassured by the ELF is relatively low. So we were hoping that at a threshold of 9.5, we would be able to screen out a lot of patients who wouldn't then need to come for additional investigations. But that's not what we found, particularly in the metabolic fatty liver perspective. It's turned out that we've screened out a relatively small number of patients, in fact, probably between 30 and 40% of people who've come for an ELF test after a FIB4 that was not low, which has meant that in the remaining 60 to 70%, we've still had to go on and do FibroScan, which because of the costs, at least that we are paying for the testing, there's probably not a big cost difference between the two tests. So unless you're excluding a lot of people with the ELF, it doesn't really make a great deal of sense, because we end up essentially paying twice for the same information. And the way that this pathway is set up, it's set up in a way that you could probably infer from the way it's set up that we believe that FibroScan is a better test than ELF. We're using it really as the arbiter test. And so if we're having to do that better tests for a large majority of people, it perhaps makes sense for us to think about doing it for everybody.
So the conclusion would be that you might go straight from FIB4 to FibroScan without stopping at ELF. Is that how that would work?
Yeah, so I think, that's one way of doing it. And that's certainly in the metabolic fatty liver population. It works a bit better in the alcohol-related liver disease population. Their ELF scores tend to be quite a bit higher, so there's much less in that sort of relatively grayer area. But what we don't really want to do, we don't want to have different pathways for different liver diseases. And that's been one of the things that has sort of developed a bit around the stratification pathways that have been published for NAFLD particularly, and that is that they are just for NAFLD and they're not for the other liver diseases. And we want to try and have a single point of entry so that you have an abnormal test, you have a fibrosis test, and then you come into the service. And it shouldn't matter whether it's NAFLD or alcohol-related liver disease or viral hepatitis or any of the other liver diseases, because all of those patients are at risk of developing liver failure and complications. So we want to try and make it as simple as it can be for primary care so that we see the right patients at the right time.
Okay, so Stephen, Louise?
I find it fascinating, and I totally agree with Ian's last statements there. I think it can be way too complicated to find a patient, to stick to one paradigm and one pathway and then look for a different one. Keeping it simple, and I use Stephen's KISS, keep it simple, stupid analogy all of the time, particularly during vaccinations that we try to make way too complicated, but make it simple. For me, I would always do the funnel test, which let's pick up, do we have abnormal stiffness? Do we have abnormal fat? Which pathways can they go through as part of that pathway? It's very, very simple. ELF, NIS4, all of these new algorithms are making it more and more complicated. And the one thing that doesn't float a patient's boat is an algorithm. And I wondered, and I just wanted to ask Ian, what was it that made the FibroScan better than ELF? Was it more than purely the diagnostic testing? Was it actually the behavioural interaction that you got with patients that engaged with it? Were there other benefits that you saw?
So that's an interesting question. And in fact, we don't have any information about the downstream aspects of what's happened. Because of COVID, we haven't been seeing patients on the same day as their imaging, and they've just been coming for the scan and going away again. And we talked a few weeks ago about that teachable moment, and that is one aspect of the service that we're currently missing. But it is one that's more easily delivered at the time of elastography or very shortly afterwards.
This is fascinating because you're playing out something in real life that we model in data sets all the time. So whether it's Litmus, Nimble, very large pharmaceutical data sets where we have lots of baseline data and we're trying to make predictive scores, all these things have kind of been looked at. We've looked at diagnosing the at-risk NASH patient by FIB4 followed by FibroScan, FIB4 followed by ELF, ELF followed by FibroScan, AST plus FibroScan fast, MAST, MRI plus AST plus MRE. All these things have been looked at. CT1 is another one in your neck of the woods where Perspectum has made lots of effort to try to become that diagnostic test of choice. So it's incredibly insightful to get your boots on ground, real world experience. And I guess I would say, are you seeing similar situations in each of those three clinics as it pertains to ELF not being as stratifying or gratifying for that perspective? For me, FIB4 is interesting because it wasn't really designed for its negative predictive value. It was designed to find F3 and F4 patients originally in co-infected Hep C HIV patients, and then kind of repurposed by Richard Sterling at VCU for NASH. What we're finding is every single one of these tests have a very effective negative predictive value. So in essence, you're trying to pull a bunch of very good negative predictive values into a tool that gives you good positive predictive value. And what's the right sequence to do that? What's the right cost-effective model to make that happen? So maybe just focusing on your diabetics, it seems like in our studies, when we enrich for diabetics, we're enriching for a NASH population that has fibrosis. And I would expect that the positive predictive values would be better than if you were just screening a general clinic.
There's a few issues in there. So we do see differences in the yield from ELF between particularly the alcohol group, where it's quite pretty good actually, probably because they've got more fibrosis, I think, and the sort of the diabetes and obesity group. We haven't looked separately between pure diabetes group and a group with obesity and other metabolic risk factors. So we haven't done that. So I don't know, but the yield in the sort of diabetes enriched group is not. I don't think that's going to be recoverable by sort of purifying further to try and improve the sort of the yield of significant fibrosis in a more NASH type population. And I think the point you make about combining tests with good negative predictive value in the hope that you'll come to a good positive predictive value is a bit like, is a bit where we are. We're sort of struggling, and we probably need to think about what the right thresholds are for what it is that we want to achieve, because as hepatologists, what we want to do is to stop people developing cirrhosis and the complications, and without as yet good interventions in the commonest liver diseases to do that, we're a bit stuck, because we're trying to work within the grey zone of the assays, trying to get to a better population for more testing and treatment, but understanding that the sort of treatment aspect of it isn't fully crystallized, so we can't tell what the benefit of really digging into that grey zone population is. Once that treatment's there, it'll be a bit easier to understand the value proposition of digging into that grey zone a bit more about where the threshold should be and what additional testing would be appropriate and when. At the moment, where a lot of our interventions at the general hepatology sense are all in cirrhosis, it probably makes good sense to have the thresholds quite high. So one of the approaches that we could take would be to put the ELF threshold up to 10.5 and say, we're not interested unless there really is a lot of fibrosis and there's something that we can offer. But we risk then missing earlier disease that we could intervene on. That's the payoff at the moment about trying to understand where diagnosis should be and where it's best placed.
I just was thinking about a conversation I was having with some of my colleagues about polygenic risk scores, and really starting to get to where we can test for PNPLA3, TM6SF2, GCKR, HSD17, beta 13. I'm thinking back to the data Rohit presented at NASH-TAG, and even a recent paper looking at polygenic risk scores to diagnose liver cancer in the setting of fatty liver. We know, even by conservative estimates, that 30, maybe 40% of HCC occurs outside the setting of NASH cirrhosis. It's more than just identifying who's likely to progress in fibrosis. It's, can we also identify the number one reason for liver cancer in the U.S., in Italy, and I think it may be behind alcohol, but I think it's very high in the UK as well. And testing for single nucleotide polymorphisms actually is pretty cheap. The problem is we haven't put together a commercial assay to do that. And my guess is, if we were able to do that and bring that to bear with you in your clinical practice, hey, let's do a FIB4. If it's positive, let's look at their genetic risk score and add that into whatever else you're going to do. Because my guess is you will enrich heavily for whatever you're looking for, whether it's liver cancer, progression to decompensation, or cirrhosis, if you were enriched for that genetic variant. And like Naga Chalasani is routinely doing that in his clinic at Indiana. And he runs the assay there at Indiana. In his mind, it really adds a lot of value to what he's doing in his clinical practice as far as enriching a population that has evidence of progressive disease. So I just want to mention that, Ian, because I think there's legs in these polygenic risk scores, and I don't want to just throw the baby out with the bathwater because we don't have a commercial assay to do that. In the U.S., we can't commercially test for ELF routinely either. So that's not something that we're familiar with outside of a clinical trial.
I guess the looking for additional tests is all about trying to understand what the risk is to the patient. That's the missing piece in our jigsaw, I think, or one of the missing pieces. And understanding what the baseline risk for the patient is today of future liver-related events, whether it's cancer or decompensation, is really important. And that's one of the things that in terms of risk-guided therapies that the cardiologists have, with your Framingham risk scores or your ASCVD scores, in terms of understanding what treatment benefit there is going to be in the coming 10 years or so. And if there are better ways, and I think we do need better tests, if there are better ways to identify that risk for now and for the next decade or two, then I think that would be a really big step forward.
Is the question then about throwing out the baby with the bathwater, or is it about making sure that you actually dedicate the right test to the right task? I mean, maybe the answer isn't always go to FibroScan, right? But the answer is to not go to FibroScan, we would need a better, more effective set of tests, the polygenic kinds of things that you're talking about, Stephen. Is that kind of where this goes?
Well, so Ian said it well. He said, look, we're not just ruling out people who don't have F3 and F4 disease. I mean, that's what FIB4 does. It rules out F3 and F4 disease. It doesn't pick up an F2. It's not ruling out an F2. It's not ruling out an F1. It's not ruling out a NASH that's a rapid fibrosis progressor. It's ruling out people that today have advanced liver disease. So that's great, but what if it's an indeterminate test, right? I mean, that's the issue. We don't want to just leave those guys and say, come back in 2 years and let's retest you, because what if that were an F4 that just was in the indeterminate, right? So we want to seek an answer to those patients. We know if it's high risk, great. We got a plan. If it's low risk, well, we tell them to lose weight and exercise and focus on their cardiac health and that sort of thing. But if they're in the middle, that's the conundrum that Ian, that Louise, that I have, is what do we do with that population? And trying to sort that out and risk stratify those people is really the holy grail to sorting this whole business out. And as we talked about at the top of the hour, finding that right sequence is critical. We know that doing tests in parallel are not as good as doing them sequentially. Quentin Anstey showed us that out of Newcastle. But what is the right test? And ideally, it would be the same test applied across multiple populations, as Ian's also alluded to. Unfortunately, our tests aren't precise enough to give us that. And it may be the way they're developed, right? These are typically built off linear regression analysis. We're looking at binary endpoints. It's a yes-no answer. Whereas artificial intelligence's neural networks are really continuous variables that allow for improved accuracy and precision modeling. And maybe we need to take what we've developed and put it back through the ringer of neural networks instead of just having a binary endpoint. I remember when I developed the BARD score, that's what I did. I mean, I looked independently at what was predictive: AST-ALT ratio, BMI over 28, presence of diabetes, and then we put it into a score based on a yes-no. Is the AST-ALT ratio greater than or equal to 0.8? Do they have diabetes or not? Is the BMI greater than 28? Yes, no. And that's essentially what was done with the NAFLD fibrosis score. FIB4, Quentin Anstey did the same thing with ABC3D, where he just brought ProC3 into the same model. So anyway, I think we're going to be hampered by the fact that liver biopsy is an imperfect gold standard, and we're going to be hampered by the fact that our tests really have binary endpoints that are put into the development of the equation. And so to get around that, you have to bring in other variables, like maybe the genetic component that hasn't been really part of any of these risk stratification scoring systems.
Anything else to add on that point, or should we go on to the next one? I think that's a good place to close.
I just thought when Stephen was talking there that we predominantly, obviously, are always talking about the patients who have been diagnosed. Now, if we look at the global population of 1 in 4 people have fatty liver disease, around about 270 million have alcohol. We have 1 in 12 of the global population with a viral hepatitis. We are still talking about the needle in the haystack. So we have our known unknowns, which I would sort of say are the patients in the epidemiology studies. We know that 1 in 4 have that sort of thing. We have the known knowns, which are the ones we've actually diagnosed, those needles in the haystack. We've actually come up with something. The unknown knowns, they're sitting in our clinics in endocrinology and cardiology, in rheumatology, or in any other clinic that's got a liver disease. They've got a marker, they've got a high risk, but they're never investigated. And I suppose for me, it's about the unknown unknowns. What can we use to find the unknown unknowns? Because those are actually the ones fueling most of the services, because they don't get found. Is that, like Ian suggested earlier, a cardiology screening program? Do we have to say that liver disease is that vast and affects so many other areas that we have to look at a uniform screening to rule it out? And I don't think any liver fat is benign. I think we're seeing that in cardiology outcomes. So where do we go with this? Mazen showed very nicely last week the cost effectivity for over the age of 40 in diabetes, but we've not even looked at the cost effectivity in cardiovascular in that same age group, who are now increasing in the mortality ranges in the UK. So I think Ian was right at the beginning when we just want anybody with liver disease. What are the best ways to discover the unknown unknowns, I suppose?
This is one of the issues that I have. And when we set this pathway up, we did it recognizing that by using fibrosis testing early in the pathway, not that early, but still quite early, that most people will not come to us. And when we in Leeds talk about liver disease, we talk about fibrosis, and that means that we are not really engaging with the vast majority of people who would be classified as having liver disease, as Louise described. And I think we as a community need to think about how we categorize patients and what we call them so that we get it right, because we've talked on this podcast before about the drive that will come when a therapy becomes available in terms of diagnosis. And if we get it wrong, then the clinics are going to end up, or the demand for clinic space and for testing is going to go up really quickly, and we're going to be seeing a lot of the wrong patient group, people who are not going to be suitable for treatment because they don't have fibrosis, and I would argue don't have significant liver disease because they're not at risk at all probably of liver-related morbidity and mortality in the coming decade. So there's a real tension, I think, in the whole of the field about what we do with this silent majority who are, and in actual fact, it's huge. The iceberg is very big, and it's not like an iceberg because most of it is submerged, not just the usual ninth, nearly all of it's submerged. And there's just that tiny cap that we have to focus on. And our testing that comes in primary care is so blunt that a lot of what's under the water that we'll never need to see is referred for additional testing. And trying to pick out only what's above the water is a huge job. And that's why the testing needs to be improved so that we can identify that group who are at risk with much more accuracy.
Why don't you talk about your model, Ian, and some of what that's showing? Because I think that the issue of teeing up cardiovascular and liver in the same conversation lends neatly into what you're trying to do with that model.
So this is a model that's taken quite a lot of time to fully develop. About 18 months ago, we started talking about how treatments for NASH might be used, or at least we did in Leeds. Obviously, people have been talking about it for a lot longer than that, and thinking about what the benefit to a patient would be with treatment. And when I've been here before, I've said talking about treating the patient, not the NASH, because we know that people who've got fatty liver disease, and NASH particularly, are at risk of death both from liver disease but also from heart disease and extrahepatic cancer. And the earlier your fibrosis stage is, the lower your risk of liver-related mortality and the greater the risk that you'll die from something else. And so we set about modelling the effectiveness of treatment. So that is how a treatment might reduce the risk of liver-related complications and liver-related death over the course of a patient's lifetime, to try and understand what the benefit to a patient might be. And we did that by stratifying by fibrosis stage, really as a surrogate of future risk of liver-related events, starting at F2, F3, and F4. And then we first did a comparison with what a treatment with a statin might be in a high-risk cardiovascular disease population, which is what our population is. So if you apply the ASCVD score to the whole of the Regenerate trial, use the average characteristics in the study, then the 10-year risk of cardiovascular events is over 10%, which is probably greater than the 10-year risk of liver-related events in the same population, which really illustrates the scale of the challenge that we have in communicating the risk of liver disease to cardiologists and to the diabetes field. But it also illustrates the challenge that a drug that only targets liver disease will have in the same population. So having looked at a statin comparison, what we've then gone on to do is to add the benefit of your drug that's treating the NASH on cardiovascular risk. So by adding cardiovascular risk reduction to your NASH drug, then you can think about what the impact for the patient would be. And broadly, what we see in a typical trial type population starting at the age of 55, that at fibrosis stage 2, comparing a 30% relative risk reduction in liver-related mortality and a 10% risk reduction in cardiovascular disease mortality, you get more benefits. You get more bang for your buck by treating the cardiovascular disease. If you do it in an F3 population with the same risk reductions, 30% for liver, 10% for cardiovascular, then liver's a bit better than cardiovascular, and in cirrhosis, treating the liver disease is much better because their baseline risk is much, much higher. And that really illustrates where the benefit of treatment will be greatest and certainly near patient benefit. But it also shows us the problems that we've had to date in drug development, because we don't have and don't feel at least very close to a drug that's going to be impactful in cirrhosis in the next, certainly I don't feel it being close in the next 5 years. And that's really where, my patients need the greatest help. The other thing that we've done in the modelling is to look to see what would happen if you had a treatment that had a cardiovascular liability, so that it increased cardiovascular risk. And I think that's particularly important given the data from Regenerate with that small but meaningfully significant increase in LDL. And we know that LDL is important in the development of cardiovascular events. It's probably causal, in fact. And you can apply small risk increases. And as the population gets older, their risk of cardiovascular disease goes up. So if you add a very small 5% relative increase in cardiovascular risk onto your 30% risk reduction for liver and F2, then what you see is that in fact that drug causes harm through its increase in cardiovascular events. And that substantiates to some extent the decision that was made by the FDA, I think, in terms of really being sure that the safety of the drug is there, where there's a signal that it might not be, before that drug is given its conditional license.
So I was playing with your model a little bit, and to amplify that further, by the time you get to people who are 65, cardiovascular pretty vastly outweighs liver, if I understand how you set your model up, right?
Yeah, that's absolutely right.
Louise, how does that align with what you were commenting on before about the unknown unknowns and really the need to address liver in that context?
It borders on, we have guidelines that recommend that for patients with NAFLD, they have a 2-year cardiovascular review. If we haven't diagnosed the vast majority of people with NAFLD, we cannot offer them that 2-yearly cardiac review. So therefore, for me, we're not preventing cardiovascular and reducing cardiovascular risk because we haven't diagnosed the NAFLD population. And as we know, that cardiovascular risk is the largest single cause of mortality in the NAFLD population. So if we don't find a NAFLD population, we can't address the cardiovascular risk, and therefore that is still going to be fueling the mortality rate. So I think that's where I come back to the unknown unknowns, because they are the NAFLD population with the cardiovascular risk that we can't offer any interventions in because we're just not seeing them at all, which comes back to a more broader range of diagnosing a sick liver, whether it's just high fat or high fat and stiffness, and adding the AST, seeing if it's a fatty liver, and then specialist review to really fine tune what's going on. But I think for me, it's if we do not find those NAFLD patients where we would advise cardiovascular assessment every 2 years, I can't see us getting ahead of the curve or even catching up in those populations. And we will still see a fueling of cardiovascular death as obesity rises at such a rate that we can't screen what we've got now, let alone the progressive obesity population rise.
Did you use the ASCVD risk score to calculate the risk of heart disease in a non-advanced fibrotic population of fatty liver patients?
No, we didn't. So we used this is a sort of baseline risk model. So we use an incidence of liver-related death each year, and then we estimate the proportion of deaths from heart disease from the total population, understanding what the rate of death is from heart disease in the big epidemiological studies. As the models come out, you can see what the 10-year risk of death is in each of the groups from that. So, in the F2 early population, it's less than 10%. In the 65 F3s, it's, 15%, which isn't that far away from the estimated risks that we see in the trials.
So a couple things. I want to share with you some recent data that was pressed last Monday. So efruxifermin actually for the first time showed reversal of cirrhosis in a NAFLD population. So that was 33% of the cirrhotic cohort that was enrolled after 16 weeks had reversal of F4 disease to F3. That was in line with the non-invasive tests also improving, the ones that were done. And so I think we're on the precipice of really beginning to separate out drug development for non-cirrhotics and drug development for at least well-compensated cirrhotic patients. I think the decomps, those that are Child B, are a completely different animal. But it may be that we could get on a path to finding something to stabilize cirrhosis and potentially reverse it within that 5-year time period, if not sooner than what you mentioned. For non-cirrhotics, if you have a drug that's well tolerated, very safe, gets at NASH, gets at fibrosis to some degree, but has a significant extrahepatic benefit, meaning atherogenic lipids are improved, glycemic control is improved, to me, that kind of crosses both of those risks, right? So now I'm targeting the ASCVD risk as well as the fibrosis progression risk. So that to me would be kind of the way I would approach this in drug development. I would want a drug that gets after, if I'm in an F2 or milder population, it's just as important. We used to think that, well, we didn't want a lot of side effects, right? We don't want to raise LDL. We don't want to have a lot of itching. We don't want to raise triglycerides. We don't want to have a lot of diarrhea and vomiting and pancreatitis. But maybe the real message is, if you're in an F2 or lower population, yes, it would be nice to slow disease, maybe reverse it, but you really need to be something that's more holistic in your approach to management of these patients, something that really gets after atherogenic lipids and glycemic control, or at least one or the other. And you need to be safe and incredibly well tolerated. On the other hand, if I have an F4 population, or maybe an F3 with risk factors, then I don't necessarily need to have the full Monty wrapped up in one drug. I can get after fibrosis in a hurry, and then buys me time, right? I treat them almost like induction therapy, and then I switch them over to something that can tackle the atherogenic risk, etc. Now, the flip side to that, Ian, is the studies like selonsertib that we've done, the Stellar 4 trial, for instance. The only people that had a CV outcome were those that had cirrhosis. The Stellar 3 population, the F3 population, didn't have any CV outcome issues. So others have shown that it's really the people at greatest risk for heart disease are those that have the greatest degree of fibrosis. So I wonder your thoughts on that.
There's a few thoughts on that. I mean, I think that the sort of the issue about the F2 or lower population, you're right, it's much less about treating liver disease in that population. It's more about treating everything else. You could turn that on its head and say, if you've got a good metabolic drug that also has some benefit on the liver, then that would be preferred. And, I think that's an interesting avenue that could be pursued. The risks of liver and cardiovascular disease as patients become older and more comorbid and more fibrotic is important, because those risks are competing. And you see in the model, at least, as time goes on, the incidence of liver-related events goes up quite quickly, but then it flattens as patients get older and their cardiovascular risk increases, and that risk takes over. Then the sample size in the Stellar 3 and Stellar 4 is still really quite small, and those patients are very highly selected, probably more selected at F3 than they are at F4 because of that sort of need for treatment. And I don't know, if you think about the size and duration of the big trials in cardiovascular, probably not enough patient years in those studies to draw meaningful conclusions about patients' overall risk of events. And that's something that I hope we'll see as outcome trials continue. One of the things that this leads you to is you begin to speculate on what the outcomes in some of the registration trials might be. If you had a drug that was good for both in F3, you might actually see that you prevent more cardiovascular events and deaths than you would do liver events in a trial that's designed to target liver disease. And that poses significant challenges both for us as investigators, but also for the regulator.
Or you have a drug like FGF21 where you're seeing, at least with the fructofurmin, you're seeing improved lipids, improved glycemic control, modest weight loss in the setting of rapid defatting of the liver, and even fibrosis modification. So the problem with those drugs is the AE profile. So that's not something we're going to give people for years and years, because we've learned from the GLP-1s that you're not going to renew your prescription that often because of the AE profile.
So what's interesting, Stephen, is you're raising a different regulatory issue at the same time, and I don't want to go here today. I'm just going to comment, which is setting patient expectations early. If patients think they're going to be on something for life and it's uncomfortable, that's harder than if they say you just need to do this for a few months and then we'll find something more benign, which takes us back to where we were last week with Mazen and the whole idea of acute versus chronic therapy at different points of the disease continuum, and the idea that goes, once you regress the disease, what do you do next? It feels like these conversations these last few weeks have been through no explicit design, circling back to some of the same issues, which tends to happen on this podcast from time to time.
Point 3 brings us back to the sort of the efficient patient journey through diagnostics. And when you've got 1 million blood tests, and 50,000 abnormal tests, and you're seeing the wave of referrals coming towards you, you're going to try and do anything to try and prioritize which patients should come and try and reduce the burden of diagnostic testing on some of your colleagues, at least in a cost-constrained and efficient system. The biggest pinch point that we were finding was an increasing burden of referral to the ultrasound department following an abnormal ALT particularly, and so at their repeated requests, we looked to see what the yield of ultrasound was in people who had an isolated abnormal ALT and who had no symptoms. And we did that through a combination of approaches. And we took 2 years worth of data of people who had an incident abnormal ALT and then went to the ultrasound department and pulled all of those patients' records. We looked to see what the ultrasound showed, and we went back to primary care and looked at their risk factor profile. So we started off with 1,500 people, and in those we didn't find any really bad findings. So we didn't find any liver cancer, didn't find any metastases in patients who didn't have symptoms. And what we did find is we found an awful lot of fatty liver, which has come as no surprise to anybody here. And what we saw was that the incidence of fatty liver on those ultrasounds increased as the risk factor burden increased. The lowest risk group, yet still having nearly 60% of scans showing fatty liver, were people who were drinking too much alcohol. The next group were people who only had obesity. The next group were people who had obesity plus other metabolic risk factors, where the probability of an ultrasound showing fat was over 80%. And then the highest risk group was those people who had metabolic risk factors and were drinking excessively, where the risk for fatty liver on the ultrasound was over 85%. And that's led us to question what the value of that scan actually is, because where the physician's pre-test probability that scan's going to show fatty liver is already very high. So if I've got a patient with diabetes who's got a BMI of 32, they come to see me and they've got an ALT of 65, then I already think that probably 8 or more times out of 10 that the ultrasound is going to show liver fat. So when the scan comes back to me showing liver fat, it doesn't surprise me, and I wonder really what I've learned from doing the scan. But at the same time, the next day I see a very similar patient and the ultrasound comes back and says there's no liver fat seen. Well, I say, well, it's fatty liver, isn't it? It's just that below the limit of the sensitivity of the assay today. And I don't think any more about it. I probably would have done a FibroScan in any case, which showed that the cap was elevated, knowing then that the patient's got fatty liver. And so because of this, we have questioned and in fact have stopped doing ultrasounds in this patient group. And this brings us to the most efficient pathway we can get to, at least today. And that is to say that a patient who has elevated ALT in the community has liver screening for additional causes of liver diseases. They have a fibrosis test, and if that fibrosis test is elevated, then they come for further testing. Don't need anything else. And it also makes me wonder whether there are more efficient pathways still, and that is, whether just doing a fibrosis test instead of worrying about ALT and other underlying liver diseases, just do the fibrosis test. If it's elevated, then you get the full diagnostic testing. You come and have your FibroScan. If it's not, you go back to primary care and you have it repeated in 3 years if you've got ongoing risk factors, or sooner if there are clinical concerns.
So what do you folks think? Does that follow logically to you?
Yeah, I like the idea of not just holding out for an abnormal ALT. As you know, we're going to miss quite a few patients that have disease that have normal liver enzymes. So I think, again, that to me that goes back to data that we hit on again in our prevalence study that just was published in J. Hep et al. That, the diabetic population, the patients with metabolic syndrome, the high risk postmenopausal Hispanic female, all those have pretest probability for having something more than just fatty liver and should, in my opinion, be tested with fibrosis biomarker or some sort of combination of tests. Maybe I'll stop there and see if you agree with that comment, and Louise, what your thoughts are. But to me, I think we shouldn't, we teased around the idea of should it be mandatory for endocrinologists in primary care to screen diabetic patients for fatty liver? And the answer was no, because we should assume that they have fatty liver. And it's just like, should we screen diabetics with the ALT or AST? Well, no, because a lot of the time they'll have disease and the liver enzymes will be normal. So we need to just take a population that has a predefined risk and just test them with something simple that has a very good negative predictive value. And then that gets us to the second comment, which is what do we do with those that have indeterminate results? So anyway, I think it's great that you don't do ultrasounds in all of these patients.
I think I agree with Stephen. Whilst I now use FibroScan as the majority of the screening, just because people should be able to access this earlier information to change behavior and give them that opportunity. Anybody we pick up with either abnormal fat or stiffness or both is actually automatically referred back to their primary care physician with information. If it's something that's serious, I have physicians who want those referrals. So for me, it's an opportunity to screen earlier. As you know, people shouldn't get liver disease over the time, but I think there has to be a mechanism at which we pitch those patients. And I think going back to what Stephen was saying there about we should assume that all diabetics have fatty liver disease, I don't think all endocrinologists and all primary care physicians assume that those patients have fatty liver disease. We hear time and time again patients coming back to us saying, they told me I had a fatty liver, but it was nothing to worry about. I don't think there is yet that understanding of how serious fatty liver is, and it's not a benign condition. We don't know how fast. We can't pick the phenotypes that are going to progress quickly through F2, F3, F4 yet. We're not that precise, and I think that goes back to, again, what Stephen was saying earlier about getting more genetic markers so that we can really fine-tune our predictability. But we've got to start with just finding those population. And if that means that everybody over the age of 11 gets an initial assessment and then is reviewed so that you know somebody's got a normal liver, you can then timeline the events to an abnormal liver. I don't know how we're going to do it, but we have a serious global pandemic of obesity and metabolic syndrome that has significantly fueled a pandemic that's viral. And we've seen that trend 3 times now in the 21st century. So I think it's a combination of everything.
I want to make a behavioral comment. I talked about this, gosh knows how many episodes ago in the context of cholesterol. But if an entire population has an abnormal measure and people are biased to think about mean median statistics, then in fact, you're just going to miss the idea. So if somebody says you have a fatty liver, but that's no big deal, that doesn't mean they can't find the fatty liver. It means they don't understand the meaning of it because it's too widely dispersed throughout the society. I think the education issue is a little different. It's a different acceptance of what's normal. As I said about cholesterol, when they started putting on lab tests that it wasn't 2 standard deviations from the mean, but it was an LDL of X or a cholesterol of Y that flagged somebody, all of a sudden people got a lot more serious about it. They simply took the data they'd already seen and they viewed it differently. And my feeling is that's probably what has to happen here, number one. I do agree, though, that in the States, the definition of defensive medicine is you have to completely prove everything 4 different ways before you do anything about it. It's wiser simply to say, if 80% of the time test A is going to lead to result X, then why am I doing test A? Why don't I just assume result X? There's tremendous logic to that. And the part of the problem in liver, Stephen pointed out, is that you can have a normal liver and an abnormal test. You can have an abnormal liver and a normal test. If we look for too much proof, we're ultimately going to be able to prove both sides of the proposition way too often. What I like about the idea on ultrasound is that we all tend to have this bias that goes, technology is always better than what's simpler. And ultrasound may not be a complicated technology, but it's technology. And it might not be a better proof than good liquid markers might be as we develop them. We talk about the polygenetic stuff, Stephen. Am I hearing you right on that?
It's not for the faint of heart. You know, Ian has taken on a big task and he's working his way through the process. And I think the first thing is you find out what doesn't work. Then you got to go hunt down, well, what does work? And the problem is for all of us, Louise, Ian, anybody in this field, you know, when we go big game hunting, we want to pull down the biggest, baddest, most accurate weapon we can have to take on the safari, right? I go to battle. I want to have the best weapon at my disposal. The problem is when Ian looks at the armamentarium of tests he has to pick from, there are not a lot of precise laser-guided munitions in his shelf, right? He's got a lot of 500-pound bombs that he kind of has to pepper everything with to try to get at the answer. And so as our ability to develop better testing comes along with drug development, we'll get better at it. We'll be more precise at identifying those patients. But part of that process is exactly what Ian is working through right now. That's how we get there. We have to identify the limitations of these tests so that we can refine the next test to make it better. And at the end of the day, we either pull the right combination of tests together together, or we find one singular test that answers the male across a broad spectrum of diseases. But it's not easy.
I don't disagree with any of that. My thought was that if you go into certain other places in medicine, not hepatology, but there are places where people have to confirm something 5 different ways to believe it, particularly in the States, because they're practicing defensively in the presence of possible malpractices and all that stuff. So you just get a lot more testing you need. Not simply a lot of 500-pound bombs, but, well, you get a lot of 500-pound bombs, and without any sense of whether what you're doing is improving specificity or simply trying to disprove more often that you're not about to make a mistake. This, as a discipline, it's a huge task, but it makes a lot more sense to me in terms of trying to find the clearest way to get to an answer that actually benefits the patient as compared to defends against mistake.
I'm just thinking about what Stephen was saying there, and it's what you do with that ammunition that's important. I use a test that allows me to see a lot of patients very quickly and give information back. And some of that can be very soft, but some of it can be nuclear bomb. And it is the ability to give that information at the right level for the individual person who's having that test, and then to facilitate the improvement of care through the pathway that's actually the skilled part of FibroScan. And I think, or any non-invasive diagnostics, if you use it in a screening way. I had a gentleman that phoned me that said, "Are you the same person that screened me 2 years ago?" And went on about how he's changed his lifestyle and his diet and everything in those 2 years and has continued it. And yes, it's me because it's the same person. But it was amazing to hear his story over 2 years. So it's what you do with that intervention and that ammunition when you go big game hunting. But what we're looking for is a funnel to bring down those patients with the broadest yield in the quickest way. And non-invasive technologies like FibroScan do that. And I think what Ian was saying at the beginning is that why use some other tests when one gives you the most information very quickly? It was just something I chose to leave the NHS for, because I can see more patients and effect in that way and get it to GPs and get it to all of those areas highly cost effective. And I think that's, for me, where we need to be progressing with liver disease, to get the right people to the likes of Ian and Stephen and through those physicians that are the minority. We don't have a lot of hepatologists in the UK. We don't have a lot of hepatologists in the US compared to gastroenterologists and endocrinologists. So we're a small field if we actually put ourselves together.
Louise, I think that's great. And I'm going to let that be the last comment for the day and a really good note on which to close. Let's go to closing question. Answer one of two, please. Something you heard today that surprised you, or the message you think people should take more broadly out of what we've been talking about today. Louise, you just kind of answered that question. I think that is the message for the day from you, isn't it?
That's mine. Ian's work's great, and I've loved his app, and I thought that was really good.
Just sticking with the military theme, I think we're the special forces of medicine. You know, we're going into the black box and trying to sort out disease and disease severity and prognosticate. And I think I take away from this that we're really good. I mean, it's just reiterating what we know. We're really good at saying who doesn't have disease. We're still struggling a bit to find the right sequence of testing to identify the at-risk population and get those to care. We're getting better at it. We'll continue to get better at it, but it's not going to be something that falls from the sky and we magically have the test and boom, we're good to go. It's like drug development. There's a lot of shots on goal and a lot of them don't go in. But we're getting there slowly, and the work Ian's doing is, I'm very proud of that, and very glad that effort is moving forward. And one of the comments you made, Ian, about treating the milder patients that have a greater risk of heart disease, I think is one that resonates well with me, and one that helps me decide as we move forward with drug development what's really important in the non-cirrhotic population.
Thanks for that. And the thing that struck me was one of the things that Louise was saying at the end, and that was about, in some ways, there are many more purposes to doing a test than simply the test itself. You know, when we set the pathway up, I guess my bias was that a blood-based biomarker that would be readily delivered in primary care would be preferred for lots of good reasons, and that is, it'd be easier, it'd be quicker, less for the patient to travel. But in fact, where that blood-based biomarker doesn't offer benefits over a patient-facing test, that is, a test that's delivered by a clinician at the bedside, there's more to be gained than just the test itself. And that is information that you can be given and changes that could be made as a consequence of that information. And trying to package that all up into the sort of the different facets of the test is really quite a challenge when you're thinking about the effectiveness of the test and its cost effectiveness, because it will change based on the intervention that's also given alongside the test.
I don't know that I have anything to add to any of that. I think this is, Steve, when you mentioned shots on goal, one of the thoughts I had was that having more shots on goal usually means you win the match, but not always, because the shots have to be the right shots, and you've got to actually get them to a place where they're actually going to get to the goal and not straight into the hands of the keeper. It's a little more sophisticated than that. And I think that's to some degree what we're talking about here, right? It's a complex process.
I do have another thought, and that I was just thinking about my clinic and how I do that clinic. So every one of my patients gets a FibroScan, and if they walk in and they don't have one, they'll often ask, "Is it time for another FibroScan?" And for new patients, if I have a negative FibroScan, the conversation is incredibly easy. If it's a positive FibroScan, I say, well, I got more work to do because I don't know if it's a false positive, a true positive. I can't predict your level of fibrosis really based on the FibroScan, particularly if you're significantly overweight with lots of sub-Q fat, and I might be overcalling the KPA and the CAP. That's where I need this next test. Now, for those that don't have FibroScan, we need it at the frontline level. But for me, I need a confirmatory test that says yes or no to that FibroScan. And I need something that's not an MR elastography or a liver biopsy. So that also is kind of a crystallization of this conversation.
With that, a great note on which to end the entire discussion for today. Ian, thank you so much for preparing all this and bringing it to us. Stephen, Louise, thanks as always. Let me let you guys go. I'll talk a little bit about business. And Stephen, Louise, I'll see you next week. Ian, see you soon. Thank you so much all. Stephen, Louise, and Ian have gone back to their days, or in the case of Ian and Louise, their evenings. So it's time for us to talk a little business.
People keep listening to the Nashtag episodes.
You people have done a great job of keeping on listening to Nashtag episodes even after the conference ended. In the last week, we've had over 150 more downloads, bringing our total to 1,250, which was the original projection. People who listen have given us great feedback about the quality of the episodes and things they've learned. So if you haven't listened much, keep listening or go back and listen.
More on our coverage of the 4th Global NASH Congress.
This week, we have our first confirmed guest surfer for the entire event, our good friend Sunil Hosmain from GenFit. Sunil was on some of our earlier episodes, and then he had to fall back and get actively engaged on a too many hour a week basis in the launch of NIS for the LabCorp deal, and then the LabCorp launch of NASH Next, which I believe is taking place this week. And meanwhile, he and his wife had to manage 2 young kids in Boston in the middle of the pandemic, so he's been away for a while. He did a great interview for us on Webcast Week, and he will be with us for the entire run of sessions during the Global NASH Congress. We'll be announcing next week who our other guest surfers will be. That run will include a preview episode that drops on April 15th. We will be recording same-day episodes at the end of April 28th and April 29th, which will be 2 o'clock in the Eastern U.S., 7 o'clock in London. We will drop late that evening in the U.S., early the next morning in Europe, and then we'll have a follow-up that will drop on May 6th.
Some miscellaneous business items.
Just a couple of small dribs and drabs to add on to. We now have country number 76 is Kyrgyzstan. I hope I pronounced that correctly. We want to thank our sponsor at Sonic Insights, who chose to feature us in their monthly newsletter, and we hope they will keep doing it. If you're getting the Sonic newsletter and this is why you are listening to the episode for the first time, you will do us a favor if you send a note to questions@surfingnash.com just mentioning that you read about us in their newsletter. We hope everybody does. Next week, we'll be talking about elastography with Dr. Alina Allen from Mayo Clinic, who we'll be having on for the first time, and I'm very excited to learn from her this week that we are her driving companion on the way to work, so she gets to return the favor to our entire audience. Finally, and as always, I want to thank our exceptional team, Mike Wilson, who makes us sound great, Eric Polly, who has his first week in his expanded role and just killed it, did wonderfully, and then you people who listen and send us letters and comments this week. I saw words like phenomenal, exceptional, and unbelievable. Keep doing that. That's what keeps us going and keeps us working to help you guys out. So good luck to everyone all week. Spring is now into full bloom. We're starting to get flowers here in Pennsylvania. When you're flowering, I hope it's lovely, and remember to appreciate it. Nature is not a given, nothing's a given. As I said last week, if you're in a U.S. state that's opening up faster than people have been getting vaccinated, be careful. I saw Rachel Walensky's talk this afternoon about being fearful of what might happen even though we're so close to the finish line, so let's all be sensible about that. Stay safe, surf on. See you next week on the podcast. Bye-bye now.
You've been listening to the Surfing the Nash Tsunami podcast. Have any questions for the surfers? You can send them to questions@surfingnash.com, and we will answer on the podcast or the website. Thanks for listening. See you next week on the Surfing the Nash Tsunami podcast.